Share screen. There. Start. Muted.
Slides.
That's all. Once each slide has hardly any information. 6 to 3 minutes. 90. Because it won't take so long, sir. Really, it won't take so long.
You should learn to cut it.
I have cut it, sir. It's just that it's.
You should learn to cut it for it.
So today we'll be talking about primarily about pharmacotherapy of Myasthenia gravis. And we'll start with a brief pathogenesis, brief types, and types of Myasthenia gravis, how to diagnose them. Then we'll be proceeding with how to treat them. The initial few slides about treatment is based on the British guidelines that was published in 2015. Followed by that, we'll be looking at international consensus, which was published in 2016, followed by its update in 2020. Fourth thing is there is a recent article on novel therapeutics which was published in 2023 in BMJ, which we'll be talking about, which has taken into consideration the 2016 and 2020 update, and based on that, they've written that. So to come to pharmacotherapy, what is my what? Admit?
That
Really?
I didn't take the thought.
Okay. So, myasthenia gravis is a neuromuscular junction disorder characterized by weakness and fatigability of skeletal muscles. The defect here is there is a reduction. Oh my God. There is a reduction in number of available ACH receptors at the NMJ. This is because of an autoimmune attack. So what we'll be talking about and why we are talking about this is there are treatments targeting underlying pathophysiological process is evolving. So we need to consider treatment based on their mechanisms, indication, risks, costs, and benefit. And also when we are targeting multiple pathomechanisms is a good approach to move forward. So coming to, this is a normal neuromuscular junction. Here we have an axon, we have the muscle, and then the neuromuscular junction where we have the presynaptic membrane, synaptic cleft, and the postsynaptic membrane. So what happens here is when there is a depolarization happening of the axon, there is an opening of these voltage gated calcium channels. Calcium enters this place. So there are multiple vesicles which are filled with acetylcholine. Acetylcholine is formed by acetyl-CoA and choline with the help of this STAT enzyme, which is choline acetyltransferase. It transfers that acetyl group to the choline from acetyl-CoA. So the acetyl group from acetyl-CoA is transferred with the help of the choline acetyltransferase to choline, forming the acetylcholine inside, and they're stored in the form of vesicles. So what happens when these calcium gets in is they migrate towards the presynaptic membrane, fuse with them, and release it. Now these acetylcholine, they pass through the synaptic cleft and then they attach to this acetylcholine receptors. Now what is this acetylcholine receptor? So it is an hexapeptide and there is a central pore. So it is formed by 2 alpha units, 1 beta, 1 gamma, 1 delta, and 1 epsilon. Totally 6 units are there. So this acetylcholine primarily attaches to the alpha unit. Then what happens? It opens the pore. Then there is depolarization in the form of entry of sodium into the channels. And then if the potential is good enough, then there is a transmission of, if the end plate potential is strong enough, then there is a transmission of impulse and there is a muscle contraction. If it is not strong enough, there will be no muscle contraction. So this is what happens in myasthenia gravis at the level of NMJ and at the level of presynaptic level. So there is first what we see is that is reduction. This is a normal neuromuscular junction where you have this is the acetylcholine receptor connected to rapsin, DOX7, MuSK, LRP, agrin. So what happens here is here you see the synaptic cleft is widened and there is reduction in number of acetylcholine in the postsynaptic membrane, and this complexity of the folds of the postsynaptic membrane is simplified. So these are the three primary issues happening at the level of the neuromuscular junction. So there is reduction of receptors, and there is a flattened and simple postsynaptic fold and a widened synaptic space. Now there is something called a presynaptic run. So what happens here is, then there is another component of MuSK and LRP and aggranule. So in each fold, there needs to be clustering of acetylcholine receptors, multiple acetylcholine receptors getting aggregated in one fold. Now this is done by MuSK, LRP, aggranule. So all the three, what MuSK does is it helps in dimerization of the, that's why it's connected here. It helps in dimerization of the acetylcholine receptors. It clusters them in one, so that there is multiple, there is more, it at a very less surface area, there is more receptors, so that it's more receptive to acetylcholine. What LRP4 does is it helps the MuSK to dimerize. So at the end of the day, MuSK and LRP4 both are responsible for clustering of acetylcholine receptors at the postsynaptic membrane. What is presynaptic rundown? It is a common mechanism. It is a normal mechanism. So with repeated stimulation, it's the process of repeated stimulation and reduction of amount of acetylcholine that comes out of the presynaptic membrane, from the presynaptic membrane, is called presynaptic rundown. Now with these issues, when there is also an additional presynaptic normal rundown happening, it causes myasthenic fatigue, because the end plate potential that is generated is not enough, and then there is no muscle contraction. This is the basic pathogenesis. So what are the mechanisms that are happening at the level of acetylcholine receptor at the NMJ? One, there is three things happen. One, there is a reduction, there is accelerated turnover of the acetylcholine receptors by mechanism involving rapid endocytosis of the receptors. The second is, what happens is an autoimmune attack. So it is T-cell mediated autoimmune attack where it stimulates antibody formation. But not only that, the specific antibody generation also stimulates the complement cascade, which causes a membrane. At the end of it, it causes a membrane attack complex and destroys the postsynaptic membrane. That is the second. Third is, it also, those antibodies also block the active site of the acetylcholine receptor. So there is blockage, and then there is endocytosis. Third thing is this destruction of the membrane. So what are the antibodies that you see in myasthenia gravis caused by ACHR, that caused by antibodies to ACHR and antibodies to MuSK? Both of them are T-cell dependent. It is a T-cell B-cell immune-mediated response, autoimmune attack. So in acetylcholine receptor antibody myasthenia gravis, IgG1 and G3 take part, whereas in anti-MuSK IgG4 takes part. This is important because IgG1 and G3, they involve the complement system, whereas anti-MuSK antibody IgG4 does not involve the complement system. So treatment-wise, eculizumab, which is an anti-complement antibody, monoclonal antibody, will work only in ACHR. It won't work in MuSK. So now also thymus involvement is a well-known fact. So just to tell us what we already know, the 75% of ACHR receptor antibody have some thymic abnormalities. Out of that, 65% are thymic dysfunctions, hyperplasia, whereas only 10% have thymomas. Now coming briefly to the types of myasthenia gravis, which you already know. One is based on the level of involvement. One is ocular, generalized. Second thing is based on the onset, which is early onset and late onset. Third, based on involvement of whether there is a thymoma or no thymoma. Then based on antibodies, we have MuSK, LRP, ACHR, and seronegative. So coming briefly to the how we are going to diagnose. So it is basically a clinical judgment which leads us to further evaluation, investigation, and management of the case. So what all does the history contain? So patient will have diplopia, ptosis, dysphagia, dyspnea. dysarthria, and there is weakness in the distribution of proximal limb, neck extensors, and sometimes even generalized involvement, primarily involving the proximal muscles. There is fluctuation of the weakness, and there is fatigability, worse with repeated activity, improved with rest. And these patients would have visited multiple doctors with complaints of fatigue. So effect of previous treatment can also be seen. Physical examination, what will we see? Evaluation of ptosis at rest and following 1-minute exercise. So we'll see ptosis, we'll see the movement of the extraocular movements, we'll look at the facial muscle involvement, jaw involvement. So assessment of muscle. So after we localize where all the issue is, then we assess the muscle strength in neck and the extremities. Then weakness. Then how do we assess this? Based on weakness followed. If we notice a weakness following repeated shoulder abduction, it guides us, it directs us more towards myasthenia. Also, we have to regularly do a vital capacity measurement. Single breath count is a simple bedside maneuver which will help us do that. And there will be absence of other neurological signs. Laboratory testing, we have the antibody testing, we have repetitive nerve stimulation, single fiber EMG, and then what we can do is an ice pack test, which is a simple bedside test and also very sensitive, and an hydrophonium chloride, which we are not regularly doing. Then for ocular and cranial myasthenia gravis alone, it's better to rule out intracranial lesions by a CT or an MRI. So coming to pharmacotherapy as such, first we'll have to look at what we shouldn't give patients. Once we diagnose, we should know what we shouldn't give. Most of the antibiotics there are 3 major group of antibiotics that we regularly use that should not be given in these patients, which are your aminoglycoside antibodies, fluoroquinolones, and macrolides. We day in and day out, even for a common cold, use azithromycin, which should not be used in such patients. And also there is an obsolete antibiotic called telithromycin, which is not used anymore. It was used for community-acquired pneumonia. Then other things is chloroquine, hydroxychloroquine, which we were giving during COVID, and then procainamide, quinine should also be not given. Then beta blockers, botulinum toxin, these corticosteroids, which we'll be talking about it later. So it is actually a primary treatment, but if you give it in crisis, it can cause transient worsening. We'll be talking about how to manage that transient worsening, how we can give and manage the weakness. Botulinum toxin, all these chelating agents like desferrioxamine, D-penicillamine should not be given. Immune checkpoint inhibitors, we'll be talking about it in little bit more detail because it's a primary focus of the recent 2020 update. Iodinated radiologic contrast agents, we don't use it anymore. The contrast agents are not anymore iodinated, so nothing to worry. Magnesium is an important thing because pregnant women with myasthenia gravis, if ever eclampsia happens, magnesium should not be given in such patients. Then we have statins. They may rarely worsen or precipitate myasthenia gravis. If at all we have to give, then we'll have to monitor their response. So these live attenuated vaccine is not that it aggravates myasthenia gravis. It's just that these myasthenia gravis are on immunosuppressants. First of all, 2 things: live attenuated vaccine are not to be given when patient is on immunosuppressants. Second, even if we do give well ahead of starting your immunosuppressant, their effect is not optimal. So we need to keep that in mind that they can be prone to these infections. So first we'll be talking about what has been very well studied even in our books, and that is your pyridostigmine, prednisolone, azathioprine, cyclosporin. So first line, pyridostigmine is a symptomatic treatment. Prednisolone is the first and the foremost immunosuppressant that we'll be trying. And then after that, as a steroid sparing effect, we have all this: azathioprine, cyclosporin, mycophenolate mofetil, cyclophosphamide, tacrolimus, methotrexate. And then IVIG, mostly given in crisis, but can be given as a maintenance dose if patient does not tolerate anything else. So coming to pyridostigmine, how do we start? We'll be talking about the pyridostigmine protocol on how to start and how to proceed. So what is the onset of action? Pyridostigmine maximum dose is 480 mg per day. That is to be kept in mind. And onset of action is within 30 minutes. And adverse effects, you'll have nausea, vomiting, mostly GI discomfort, and sweating, cramps, salivation, blurred vision. How do we handle this? These are all cholinergic effects. We can give drugs like mebivarin and propethine. Both anti-muscarinic agents can be given to handle the gastric set. So monitoring, use the minimal amount that produces clinical improvement. This is the best achieved by using a dose that produces observable improvement. So there is no like laboratory investigations that we need to regularly do. To give all these agents anticholinergics to counter the effect of the cholinergic effect of this. Prednisolone, we'll be talking about this again in detail on how much to give, the protocol. Onset of action is in 2 to 4 weeks. This is important. So the first immunosuppressant that we'll be giving, this is the quickest acting actually. 2 to 4 weeks it takes. And then other usual adverse effects of corticosteroids, need to monitor HbA1c, bone density, to look for what is that? Glucose monitoring and osteoporosis. We need to regularly monitor because it's a long-term steroid. So now coming to azathioprine or the steroid sparing agents. This is a very important topic. So how do we start? We start at 50 mg per day and then we increase it by 50 mg every 1 to 2 weeks. So the target is to reach 2.5 to 3 milligram per kg per day. So the response you will start seeing at around 12 months. 8 to 12 months, but the maximum response you see after 2 years. That is, it takes long. Like we saw steroids, it takes couple of weeks to see the effect, whereas these azathioprine, it takes to start showing any action, it takes 6 to 12 months, and the maximum effect is seen after 2 years. So you'll have to wait. For us to even see a visible steroid sparing effect, we'll have to wait. The major complications are GI upset, leukopenia, hepatotoxicity, and skin rash. The skin rash, I just thought it was worth mentioning. Azathioprine causes something called sweet syndrome, erythema nodosum. It is neutrophilic leukocytosis that happens locally at the level of the lesion. So what do we monitor and how do we monitor? Because of all these side effects, we need to monitor CBC, LFT first frequently. As we increase the dose, we have to monitor frequently. It's also given in some articles that the moment you see some sort of leukopenia is when you know you have reached an optimal dose. So CBC, LFT 1 to 4 times in the first month. So as you increase every 1 to 2 weeks, you will have to monitor. Then once you've reached a stable course, then monthly to every 3rd month. So first, then every month for 3 months, and then every 3rd monthly. Regular dermatological examinations if taken chronically. Now, 10% of patients cannot tolerate because of the flu-like reaction. There is an enzyme called thiopurine methyltransferase, which needs to be checked. It's not a contraindication if there is deficiency, but if it is absent, it is definitely a contraindication. People with TPMT deficiency on giving azathioprine, it's the same mechanism, causes significant myelosuppression. That's right, it causes bone marrow suppression. So that is that. So the dosage of azathioprine to start is 50 and reach 2.5 to 3 milligram per kg per day. Cyclosporin 100. So 100 mg twice a day. So you have to increase slowly as needed to 3 to 6 mg per kg. So the first one was 2.3. Cyclosporin is 3 to 6 mg per kg on a BD schedule. So this takes around 1 to 3 months to take action. It is contraindicated in pregnant women. It can cause hirsutism, tremor, gum hyperplasia, hypertension, press. 2 drugs which to remember we need to that cause press among the myasthenia gravis ones are cyclosporin and tacrolimus. And so because of all these side effects like hepatotoxicity, nephrotoxicity, we need to check at CBCs, LFTs, renal functions. Then first initially monthly for 3 months and then every 3 months monitor through drug levels. Both tacrolimus and cyclosporin have drug levels which can be monitored. They say in cyclosporin avoid brand switching because apparently bioequivalence is different for each. Mycophenolate, 500 mg twice a day. You can go up to 1000 to 1500 twice a day. The effect of action is like azathioprine, 2 to 12 months to come to work. Same, they have again GI, whatever causes all these cells which are more prone for destruction, like our gut cells. The side effects correlates with that. Our blood cells, our gut cells, kidneys and livers, which is the most common side effect we'll see. So diarrhea, vomiting, leukopenia, teratogenicity is also seen. CBC, so in this patient, CBC weekly for 4 weeks, every 2 weeks for 4 weeks, and then monthly to every third month. So my REMS program, when used in women of childbearing age, in pregnant women, to definitely contraindicated, but there is a program issued by the US FDA where there you have to see the pros and cons of what is the benefit of this over the side effects of this, especially in the children of childbearing age. That's the REMS program. I don't remember the full name. So diarrhea may resolve by change to TID dosing. Cyclophosphamide, you can either give oral or IV, 50 mg per day, or IV 500 mg per meter square. So orally, if you are giving, you can reach up to 2 to 3 milligram per kg per day, very similar to the azathioprine dose. This also takes 2 to 6 months to show effect. All of these are in months, except for steroids, which are in weeks. Alopecia, leukopenia, nausea, vomiting, skin discoloration, hemorrhagic cystitis, malignancy, all are side effects. Same assessment of CBC, renal functions, liver function every 2 to 4 weeks. And urine analysis to look for any blood, active urine in case of hemorrhagic cystitis. IV pulse doses are less toxic because the cumulative dose is less, not you take every day. Tacrolimus, in this, you have to give 3 to 5 mg per day. There is no dosing. You have to see the levels of tacrolimus, and then the trough levels should be around 8 to 9 nanogram per ml. That is the advisable trough levels. So you continue to increase. You start at 3 to 5 mg per day and continue to increase till you reach that trough level. Steroids are not the only one which cause hyperglycemia, HHH, hyperglycemia, hypertension, headache, hyperkalemia, nephrotoxicity, diarrhea, nausea, vomiting, press. All these are side effects of tacrolimus. Same monitoring of those, whatever side effects like your renal functions, potassium levels are to be done frequently. Methotrexate, there are no major studies indicating the efficacy of methotrexate, but it's expert consensus that methotrexate can be used according to the 2020 update. So you can give around 5 to 15 mg weekly for 2 weeks, then increase as per that. So this is little more than what we give for rheumatoid arthritis dosing. So we can increase up to 15 to 25 mg. And this also takes months to act, 2 to 6 months. The usual, what we can do, the side effects of ulcerations, leukopenia, GI abnormalities, hair loss, hepatotoxicity. Pulmonary fibrosis is actually a very rare complication. Teratogenicity is well known. Nephrotoxicity is also quite rare. You can give, in such patients, you can give folic acid supplementation. It acts on the folate pathway. So you can give 5 mg per day to reduce toxicity. It's contraindicated in pregnancy. So we know that MMF and methotrexate are contraindicated in pregnancy. IVIG, you as in during crisis or impending myasthenia crisis, we give 2 gram per kg, and then maintenance dose, not well studied, but can be given if if people are contraindicated or are not tolerating the rest of the immune suppressants, then we can try this. So in IVIG is contraindicated in IgA deficiency, so it's better to monitor that. And it can cause all those to be avoided in patients of ischemic events recent, because it causes hypercoagulability. So better to avoid in those unless and until required. It is said, this is new for me too, use sucrose-free formulations for patients at risk of renal toxicity. So coming to the guidelines, so first, these are the British guidelines. These are not the international consensus. First, we're talking about what all it includes. And then we'll be talking about the definitions that it has, that the consensus have established. And then we'll be talking about the treatment. So what they include, the guidelines include symptomatic and immunosuppressive treatment, IVIG, plasma exchange, impending and manifest myasthenic crisis, thymectomy, juvenile myasthenia gravis with MUSP, and then myasthenia gravis in pregnancy. Management of all these has been included in this consensus. Preliminary definitions. What are the goals of treatment? In simple words, post-interventional status is nothing but, this is the TAR scores. The post-interventional status is what is the status of the patient after continuing the treatment. So according to their classification, MMS or CTCAE are the goals of treatment. What is CTCAE? 1 are the goals of treatment. What is this MMS? Minimal manifestation status. So the patient has no symptoms of functional limitations, but has some weakness on examination. So this is very close to remission, but only on examination we are finding some objective weakness. So the class recognizes that some patients who otherwise meet the definition of remission have mild weakness. So remission with mild weakness is MMS. So CTCA grade 1 medication side effect is nothing but patient has hardly any side effect, that is asymptomatic or only mild symptoms. So you're taking some medicine, and then post-intervention, after taking that medicine, if you have reached an MMS status and you don't have much issues with the medicine, then you've achieved your goal. What is remission? Patient has no symptoms or sign of myasthenia gravis. What is accepted here? Weakness of eyelid closure is accepted. So you can call the patient is in remission, but if the patient has weakness of eyelid closure, but no other weakness, then patients on pyridostigmine are not to be taken. You should taper the patient of pyridostigmine, and in spite of that, patient has no symptoms or no signs, then they are in remission. What is ocular weakness? Ocular myasthenia gravis. Any ocular muscle weakness may have weakness of eye closure, but the facial, bulbar, and limb muscles are not involved. So, ptosis, diplopia, two major complaints ocular myasthenia people will have. So, notice it is recognized that some patients report fatigue when strength testing is normal. That is a sign of generalized myasthenia. So, like the physician needs to take into account that. And this ocular myasthenia gravis is based on dysfunction that the physician sees at one point of time. It is not dependent on the duration of the disease. So it's at one point of time evaluation. If the patient has only ocular weakness, you call it ocular myasthenia gravis. What is an impending myasthenic crisis? According to the physician, basically, so there is rapid clinical worsening of myasthenia gravis that, in the opinion of the treating physician, could lead to crisis in the short term, in a matter of days to weeks. That's impending myasthenic crisis. So what is manifest myasthenic crisis? It is a crisis which focuses on basically clinical implications. So there is a serious life-threatening worsening illness, rapidly worsening illness, which causes airway compromise and leading to airway compromise because of bulbar and the ventilatory dysfunction. So these patients require NIV or intubation. And they require, because of the illness, if they require NIV intubation, you can put it under manifest myasthenic crisis, but exclude if it is post-operative. What is refractory myasthenia gravis? So post-interventional status, that is after treating, the patient's condition is unchanged, or if it is worse, after corticosteroids and at least 2 other immunosuppressive agents used in adequate doses for adequate duration. And in spite of that, patient is having persistent symptoms or having side effects from the immunosuppressive agents, and it is causing significant limitation of activity of the patient. So then it is called refractory myasthenia gravis. So immunosuppressants used, totally 3 medicines. One is corticosteroid, 2 immunosuppressant used in adequate doses for adequate duration. Patient, in spite of all that, having symptoms or side effects because of the medication, and this is causing issue with their day-to-day activities. Now coming to treatment. So this treatment is just to give an overview on, this is according to the British guidelines in 2015, just to give an overview because the international consensus does not explain everything. So What all do we do in ocular myasthenia gravis? Simple, pyridostigmine. If pyridostigmine does not work, then you have to give prednisolone. Then in such patients less than 45, AChR antibodies positive, consider thymectomy. Only these three. So if symptoms, and then we'll be talking about further. So when to start immunosuppression in ocular myasthenia gravis. Okay, so this what it says is on trying to withdraw or you're unable to reduce the steroid dose less than 15 to 20 milligram on alternate days or 7.5 to 10 milligram per day on a daily dose. So then you have to consider immunosuppression. So if the patient is having relapse symptoms, if you reduce the dose, then you have to consider immunosuppression. What do we do? Pyridostigmine dose escalation is very similar in ocular and generalized myasthenia. So how do we start? We start at 30 mg 4 times a day for 4 days, 60 mg, then after that increase it to 60 mg 4 times a day for 5 days, and then increase it to 90 mg 4 times daily over 1 week if required. So the duration of action varies and some patients require 5 daily doses. Okay. So first 30 followed by 60, you can go up to 90 4 times daily over 1 week. The pyridostigmine dose, if it does not control the symptoms satisfactorily, then we need to add prednisolone. So this is the same dosing for ocular as well as generalized myasthenia gravis. 30, 60, 90, 4 times. Management of side effects. Withdrawal, if using pyridostigmine monotherapy, lowest effective dose needs to be prescribed. But after starting prednisolone, you see that patient is almost in remission, then you can withdraw pyridostigmine at the rate of 30 to 60 mg per week and use the lowest effective dose. Now, how are we going to start prednisolone in these patients? How much to start? How to go forward? Now you have to start at 5 mg on alternate days for 3 doses. Then keep increasing 5 mg every 3 doses till patient has no symptoms. So the maximum dose in ocular myasthenia gravis is 50 mg on alternate days or 0.75 mg per kg on alternate day. This is a better one. So 50 mg or 0.75. What is a clinical remission on what is it after, like what are we supposed to look for? What is our goal? Clinical remission on corticosteroid treatment. So the absence of symptoms and sign after pyridostigmine withdrawal. So you give pyridostigmine, patient is having symptoms, you start prednisolone at this rate. Then at some level, after an optimal dose, patient does not have any symptoms and slowly you withdraw pyridostigmine. After pyridostigmine withdrawal, at a certain steroid dose, patient will not have any symptoms, and that is called clinical remission on corticosteroid treatment, and that is our goal of initiating immunosuppression. Some patients are resistant to corticosteroids. After 3 months, you see no response. You keep increasing and you've reached the maximum dose, no response is seen. Then we need to consider adding immunosuppression or steroid sparing immunosuppression. And that is going to take long to act. So in this, 2 major things: monitor your blood sugars, bone protection protocol needs to be followed. Here we give calcium, in some places they give bisphosphonates for that. Prednisolone withdrawal. Now, okay, we spoke about first pyridostigmine initiation, pyridostigmine withdrawal. Then we spoke about steroid initiation. Now we'll be talking about steroid withdrawal. Prednisolone withdrawal for ocular myasthenia gravis. How to reduce? Now you have to, only after achieving remission for at least 2 to 3 months, you should even think about withdrawing. And the plan is to titrate it down to the lowest effective dose. So how do we reduce? So reduce by 5 mg alternate day per calendar month down to 20. So 1 month, in a month, you reduce by 5 mg. Every month you reduce 5 mg till you reach 20 mg. Now, once you reach 20 mg, you reduce 2.5 mg every month till you reach 10 mg. Then you reduce 1 mg per month slowly and have a baseline of and maintain it at 7 to 8 mg on alternate days. So reduce it by 5 mg. So assume if the patient is on 40 mg alternate day steroids, you reduce it by 5 mg 4 months. After that, you reach 20 mg. Then after 20 mg, you reduce it by 2.5, 4 months, you reach 10 mg. After you reach 10 mg, reduce it by 1 mg per month. If the symptoms recover, you have to go back to the prednisolone initiation protocol, which I told you. So corticosteroid maintenance and criteria for introducing immunosuppression, very simple, 2 criteria. If the dose that they're using is 15 to 20 mg on above 15 to 20 mg on alternate days, it's too high for long-term use, introduce the second agent. And if the patient is having intolerable corticosteroid effects, introduce the second agent. That is the second non-steroidal immunosuppressive agent. Now, treatment of generalized myasthenia gravis, same thing. So the pyridostigmine dose escalation protocol is the same. Then the thing that we need to focus is steroid initiation. So pyridostigmine initiation and withdrawal will remain the same. 34 times a day for 4 days, and then 64 times a day, then increase it to 90, 4 times a day. So the protocol for, and while reducing, you reduce it by 30 to 60 every week once you have reached remission. Protocol for starting prednisolone, you start at 10 mg. There we started at 5 mg, inocular myasthenia gravis. Here we are starting at 10 mg on alternate days for 3 doses, increase by 10 mg every 3 doses until symptoms improve. Their max dose was 50 mg. Here max dose is 100 mg. There our target was 0.75 milligram per kg. Here it is 1.5 milligram per kg for generalized. And it may take months to achieve full remission. So remission on corticosteroid therapy, the absence of symptoms and signs after pyridostigmine withdrawal. So if not in remission, 3 months of corticosteroid, initiate non-steroidal immunosuppression. The same thing, bone protection protocol, sugar control, the same, only the dosage is different. So the withdrawal is also different. So there you were reducing 5, 4 months. And here the dose is obviously going to be more than 40, right? So because the maximum dose itself is at 100. So you can reduce 10 mg every calendar month down to 40. So the patient is on 80 mg every calendar month, we reduce 10, then become 70, then become 60, 50, 40. Till 40, you can reduce it 10 mg per month. After that, the same thing, 5 mg per calendar month till 2 months, till 20 mg, 2.5 per calendar month till 10 mg, and then below 10 mg every 1 milligram per month to maintain at 7 to 8 milligram on alternative. So it's literally the same thing. The corticoid, what are the indications in generalized myasthenia gravis to start immunosuppression? If the dose is too much, that is more than 15 to 20. Intolerable side effects, patients who do not achieve remission after, that is 100 milligram. It may take months, but even after 100 milligram, patient is not achieving remission, then you start the second immunosuppression. So some appear to fail to respond to recommended doses of prednisolone. That is because it can be because of the slow response to steroid. It may take 3 months and sometimes much longer. And the second is insufficient dose. Immunosuppression should be considered early in patients of diabetes, osteoporosis, ischemic heart disease, or significant bulbar or respiratory weakness that do not respond rapidly to corticosteroids. Also, one more thing, in patients with diabetes mellitus, steroids not alternate day regimen, but daily dosing will be a better for better sugar control. Daily dosing will be better. So in these patients, second immunosuppression initiation can be done early. So coming to immunosuppression, this study primarily talks about azathioprine as a first-line agent. So what in immunosuppression, one note that I wanted to make is immunosuppression and vaccination. Vaccines are less effective in immunosuppressed patients. Live vaccines are absolutely contraindicated, and there is an increased risk. Patients requiring immunosuppression should have their vaccinations updated, like your pneumococcus influenza, Haemophilus influenza, and varicella zoster. So these vaccinations before initiating immunosuppression can be given. This we already spoke about. Azathioprine is the first line agent TPMT deficiency is not a contraindication, but complete absence is a contraindication. So how do we do? Azathioprine should be increased over 1 month to a maintenance dose of 2.5 mg per kg. That is, every week or every 2 weekly, you can increase the dose and reach an optimum dose of 2.5 mg. Blood tests should be monitored weekly as the dose is titrated upwards. That is, we were doing blood tests as per the previous slide, that every week till 4 weeks. And then it is slow to achieve maximum effect. To achieve a maintenance dose of prednisolone of below 20 mg on alternate days after 2 years. That is our goal. Steroid sparing effect is our goal. So failure to